Afternoon, and welcome to today's School of Medicine virtual town hall, a conversation about race and mental health. I want to thank you for joining us today. And I have here a real esteemed group of experts to engage in a conversation about this critical issue here today. And I'd like to start the conversation by asking Anise Weaver to introduce herself.
Thank you, Dr. Ben Reese. My name is Anise Weaver, and I am a Director of Clinical Operations with the Department of Psychiatry and Behavioral Sciences. I have a number of years of experience leading programs in the behavioral health setting, primarily in New York City, and an honor to sit here before you with my respected colleagues. Now I will turn it over to Dr. Damon Tweedy for his introduction.
Hello, I'm Damon Tweedy. I am a psychiatrist, an associate professor of psychiatry here at Duke. I've trained and been at Duke for many years. I am involved primarily in the medical education side here on campus, and I also am involved in clinical work over at the VA across the street. And I'm going to turn it over to Dr. Ernestine Briggs King.
Hi, everyone. I'm Ernestine Briggs King. I am a clinical community psychologist by training. I have lots of experience, over 20 plus years of experience providing mental health services for children and families who experience trauma. And I'm excited to be here with all my colleagues.
Well, thank you. I'm really looking forward to this conversation. And I hope that those of you who are online this afternoon were also available and heard the School of Medicine's town hall on stress and well-being on July 1st. And we realize that people are really struggling during this period. You know, stress level is high. We have really a lot of challenges with the pandemic. And certainly structural and systemic racism, which has really been heightened and focused on across the country, and certainly within the School of Medicine. And so we think and we hope that today's conversation will surface some of the complex issues related to structural racism and mental health, and hopefully give you some ideas and thoughts about how we move forward from this day on. You know, I think we all recognize that one of the impacts of systemic and structural racism is on health, both physical health and mental health. You know, the pandemic has certainly highlighted the notion that although everyone is susceptible to the virus, the impact is not the same. And certainly those people of color are exposed and show disparities in terms of infection, disparities in terms of hospitalization, and disparities in terms of death. And none of this is new. You know, many of us, certainly everyone on this panel today, recognizes that issues of systemic and structural racism and its impact on health have been with us for a long time. But I think the current national situation has shown a light on those issues. And I think it's incumbent upon all of us to take this opportunity to really delve more deeper into these issues, and certainly in a very active way, work to dismantle structural and systemic racism. And so this conversation today is just that. It's a conversation. We won't be making presentations, but we'll be engaging with each other about this topic and using the expertise that I have with me today, and I'm really excited to have these experts here, but using this opportunity to have an informal conversation. And it'll probably raise lots of questions for folks. And so you can certainly send those questions in. You can put them in the chat and we'll respond to them in the days ahead. But I think we're going to use every moment of this time together and this opportunity to have folks here to delve into this important topic. And so I'd like to get us started, and Anise, maybe we can start with you. You've got, over 15 years experience doing this work. Can you give us a sense from your perspective, just how has race and racism impacted the work that you've been doing?
Sure, sure. So throughout my career, I've often been one of the only members of leadership teams that identify as a minority. I've had to defend experiences of minorities in various settings and demonstrate cultural humility in meetings with colleagues. These experiences shaped how I lead in the workplace. One of the benefits of working in various settings is I've had a chance to see what works and what doesn't work. So for the purposes of this question, like I've seen racism play itself out and be checked when leadership teams outwardly express the rejection of bias and microaggressions that tie into racism. And for example, I worked in a setting where a clinician referred to a patient as a good slave and thought it was a compliment to that patient and would inspire other peers to be more like that patient. And I witnessed that clinician receiving counseling because essentially that clinician viewed that patient as if he was a Frederick Douglass. Now I was part of a team that addressed that comment and its repercussions. That comment created unrest and unease among staff and patients. A town hall was held. It also echoed additional conversations between the clinician and other colleagues. Now this was years ago, panel, and yet it still resonates inside of me. Yeah. And I've also seen examples of partnership among racial lines exist, not just between clinicians, but executive leadership as well. Where I've seen individuals see this and it speaks volumes. It leaves, when I have seen situations like this, it essentially leaves less room for racism to grow. Yeah. It's essentially the power of the parallel process. There's something powerful that occurs when people name that partnership, essentially saying white, saying Black, confidently in discussions. It doesn't need to appear to be a secret. Race and color isn't a secret. And I've also seen different levels of competence vary on the level of experience that people have when it comes to treating minorities. The majority of faculty, staff, and learners could learn more on how to show up for minorities. And that's generally speaking. Even those of us who have done a self-assessment years ago and have coined ourselves as individuals who get it, could in fact do more. And so, Dr. Reese, I see us as being in a space where it's a new day. The variables that impacted people of color years ago, they've changed, yet some remain the same. And so minorities are part of a system that knowingly knows that they are at a disadvantage. And essentially the cover has been lifted up. So I challenge us, what are we gonna do? And I hope that we will not ignore the issues that minorities are facing anymore.
Oh, thank you. And you make the point about how people are using the language, using the words. Mm-hmm. We're no longer, using coded language for what clearly to me is a history of ingrained racism. And when you give that example, it makes me think of, the example of George Floyd's murder. Certainly not the first murder, but I wonder, Damon, when you think and reflect upon that murder, how has it impacted the patients that you treat?
Yes, quite a bit. I mean, I think, first and foremost, it kind of, reinforces that perception that law enforcement,
I think, Damon, your video is freezing. If you turned off your camera for a moment, maybe we could, it would be easier to hear what you're saying.
maybe threat than a protector. Hello, did I zip out there for a little bit?
You went out for a little bit.
Oh, I'm really sorry about that, everyone. I'm back now, Ben. Am I back?
Yeah, good. Yep, you're clear.
Okay. Yeah, I'm sorry, really sorry about that. Yeah, so I guess what I was just saying is that in some ways it kind of reinforces that perception, and it sort of adds to the many names that we've sort of come to hear about in recent years, who sort of, there's a kind of laundry list of names, and so it certainly kind of reinforces that. It also requires people relive their own kinds of experiences with it.
Yeah.
I've been thinking about that, so like for instance, I had my own experience as a young medical student where I was pulled over, as a medical student here in rural North Carolina. And and the encounter was very threatening, and it was I was accused of having a firearm and having drugs and all these sort of things, and it was a very frightening thing to experience, and it was a kind of sobering reminder. I just left the campus of Duke, and I was back on the road, and just this idea of sort of this perception of how you can sort of quickly, your perception of you in the world can change very quickly. So I think there's that side. Within some of the patients I'm seeing, I'm also, there's also this idea of like people, we have video access to these things and watching them over, and there's this real concern about that. That can sort of cause its own sort of trauma, and not only reliving your own trauma, but seeing this in live time and then being able to see it in a loop. And so I've been actively discouraging people from doing that. Also from getting into sort of these online forums where these kind of discussions can kind of take place that are also pretty, you also kind of can get yourself down a rabbit hole, which just sort of furthers your sense of despair. So there's a lot of that's tied into this that I've been seeing.
Yeah. Man, you describe very vividly racial trauma. Exactly. And how watching this stuff on TV is painful for anyone. Right. But for Black folks, it has a particular meaning. Yeah. So I wonder, Ernestine, following up on that, how has everything that's been going on impacted communities of color? And how is that different from the general national community?
Yeah, I think the combination of the pandemic and the social injustice issues and discrimination and racism and all the things that we see are having a compounded impact on people of color. I just think back at all the things that people of color contend with, and think about like mental health in that context. And we can think about the rates of mental health in African Americans are similar to those of the general population. And yet significant disparities in mental health services exist. If we look at the numbers, approximately a third of African Americans who need services receive them. They're less likely to receive high quality services or even evidence-based treatments. They are often misdiagnosed, which has implications for treatment and recovery. And when African Americans do receive treatment, it's often in the context of primary care, emergency rooms, or inpatient services. Now, in fact, these gaping disparities in care are the basis for starting Minority Mental Health Month back in 2008. The thought was bringing attention to decades of disparities which serve as a catalyst for change. And we could talk for hours. We probably need a few hours more, Ben, to talk through how the insidious nature of bias, discrimination, and racism has really led to these disparities. I would encourage those listening to learn about the history of Blacks and people of color in the United States and how pain points like the Tuskegee experiments or the eugenics movement really contributed to these disparities, but also contributed to inferior treatments and mistrust of health and mental health providers. I think many moons ago, I read this book by Robert Guthrie entitled, Even the Rat Was White. It really helped me to understand some of the complex factors that have led us to this point. And, I think though accessibility and availability and affordability of services are big barriers that we have to overcome, I think the other big obstacle that we don't talk enough about is stigma, or the shame we attach to seeking help. I just think, how many of us grew up in households where we were told not to air out our dirty laundry, or where we saw family members or friends struggling with mental health issues, but we just didn't talk about it or even encourage them to seek help? We don't want to appear frail. We don't want to appear weak by asking for help. And so in the end, many of us just struggle in silence. We don't want to enter systems that create opportunities for rejection and humiliation or even deportation. So, the options are limited. And I think back to that example that Anise gave, which was so telling of, so many folks' mental health histories and interactions with the mental health system that is just so negative, and how that impacts their willingness to seek help. So we got to change the narrative. We got to let folks know that they don't have to suffer in silence, that there are high quality treatments that are available. And as practitioners, we have to be aware of what we bring to the table, our own biases, and figure out ways in which we can become culturally and linguistically competent to really meet the needs of diverse people of color.
Oh, no, thank you. I mean, it clearly isn't one issue. I mean, you're really describing, issues of availability in terms of resources, stigma in terms of certain communities, certainly the Black community, and then the need for clinicians to really think about what they know, the content of their knowledge about diverse communities, the potential for their own bias. And in starting this conversation and learning and helping people learn more about the complexities of race and mental health, and Nisa, I wonder, I'm thinking back to your comments, how can we help communities learn more about mental health, particularly mental health related to race?
Yeah. I mean, so I just want to piggyback a bit on what you both mentioned, just in reference to the diversity and the complexity. So this is a time more than ever where underrepresented groups need to take extra care of their mental health. As illustrated by the panel and moderator earlier, there are various external barriers that distract people from taking care of themselves. And quite honestly, it's understandable. As a minority, like I literally see the news, read articles, and there's a consistent message that tells me that myself, as well as my family and close friends, at a higher risk of dying due to circumstances outside of their control. So that, coupled with the horrors of racism, is undeniably challenging. And in my experiences, like some people want to talk about it and some people don't. And I think we need to respect that. Some want to share their personal experiences and some don't. And we essentially need to respect those boundaries. We have a number of people that have developed survival strategies that don't align with the notion of speaking up. And then we need to essentially respect those boundaries. I wouldn't dare neglect also those individuals that, essentially their voices are now hoarse because they've been speaking year after year, day after day. So I think like including all, variables is key. In addition, I'm also aware that we should have more faculty, staff, and students of color as part of our team. I think we all could agree that that's evident. However, in the meantime, those that are in the role of a provider of service need to improve their competency. In 2020, I believe it's a poor excuse to say that we need more Black clinicians to treat Black patients solely as if it's a simple solution. It's part of a central problem, but what we have is, it's a complex issue. So I challenge all those that are watching, as my colleague Ernestine mentioned, I challenge all those that are watching to take your temperature and step it up. That's one thing that we all can identify with. And that, coupled with like doing a self-assessment. Part of the work, that what we need to do and we're called to do, it includes self-reflection and even taking an opportunity to look at your own patient panels, looking at your own data. And it doesn't have to be complex. Taking a look at your panels and seeing how many patients of color are in my rotation and how many people of color am I seeing and why. I think we naturally want to treat those who we can help. And if we don't do the work to assess our own biases, there will remain a number of people who don't receive quality care as a direct result of that bias.
Yeah, and it's not only about the structural changes in systems, but it also it's about us as clinicians.
Correct.
Yeah. And when you mentioned taking our temperature, I recognize, we all recognize that in addition to the issues of structural and systemic racism that are being highlighted, we're in the middle of a pandemic.
Mm-hmm.
So Damon, how have those two things, you think, impacted communities of color? And I mean, how do we think about these two major things happening at the same time?
Yeah, I mean, 2020 has just been,
Oh,
it's been so difficult. I wanted to follow up on Anis's last point about
sure.
the providers. And I think it's also really important for those providers to realize that, the patient, when they walk into the room, the patient is bringing their own history and how they might, in terms of how they might interpret that provider, their actions, their behaviors. So for me, as a really tall African-American male, I've been mindful of that my whole life. How are people going to perceive me when I walk into a room, right? But I think a lot of people take those sort of things for granted. It's like, what is this patient bringing to the room? How might they see me? What can I do to sort of alleviate some of the concerns they may have? I think that if you come into it with that frame of mind, it can make things a lot easier. So just wanted to piggyback on that. But as far as COVID and the pandemic itself, yes, I mean, just as a disclaimer, we know that COVID-19 has impacted everyone in all sorts of ways, right? I think it's fair to say, though, that the impact has been disproportionately harmful to the Black and Brown communities, and there's several ways in which I've been seeing that with the patients that I've been seeing. So there's that old adage, right, that when white America gets a cold, then Black America gets pneumonia, right? And so that's an old adage for those of you who haven't heard it. It's something that you kind of grow up hearing a lot. And with this being an infectious disease, I mean, it's all the more a relevant tale, right? I mean, statistics sort of bear it out. And so when you first hear that, that COVID-19, when the news reports started to come out that it was more common among African-American people, there's certain reactions that you might have. One reaction is, of course, I'm not surprised, but then it's also, here we go again. So there's also that sort of psychological kind of kind of thing, as you said, you're sort of hit with, right? And so there's all sorts of emotions that you might feel. You might feel anger at that. You might feel sad. You might feel like I got to take action. So all these sort of emotions I'm seeing from people that I see. There's also a really more practical side of this fact that COVID-19 is disproportionately harming African Americans. That means that African American patients are much more likely to have people that they know personally who have suffered the ill effects of COVID. So I've had patients who've had family members who have contracted the virus and have passed away. And so then that leads us to the next layer of like, well, is interfere with our grieving rituals, right? So a person's family member dies, and then they can't get together in the way that they might historically have done when I come from a very large family, and there's a certain ritual to the fact of funerals, and so that can't happen. So that's disrupted as well, and so there's all the other sorts of psychological barriers that are at work there, where sort of the grieving process being interrupted. So there's a lot of different layers there. The final piece I'll say is that with some of my patients, I've noticed the physical distancing has been a real challenge for them in a assortment of ways. There's one guy who I've been seeing who's big part of what he does is mentoring young Black men. And that's a big part of, and it's a very hands-on kind of work he does both at the school and outside of the school system. And with all that changes, that really caused a great interruption. He was so worried about what would happen to those students that he was mentoring in a very, very close and personal way. And then it was starting to impact his own sort of mental health. And he was starting to find that some of his anxiety and depression symptoms that had been sort of at bay had sort of been re-aggravated by his concern about what would happen to these men that he'd been mentoring. So there was kind of this reciprocal relationship. So there's so many layers to how people are affected by this pandemic.
And as clinicians, it takes a level of insight and understanding of mentoring and how that occurs similarly, but also differently within different ethnic and cultural groups. And so without that cultural knowledge, humility, without that, you're at a disadvantage.
Yeah.
Several of you, including myself, have focused on and made comments about clinicians and the necessity for them to reflect on themselves, their own skills, knowledge, competencies, etc. Are there ways that clinicians might do that you would recommend, or how does one, sort of assess where you are in your cultural knowledge, sensitivity, competence? I mean, in a real practical way, what are the suggestions that you would give? Not to put anyone on the spot.
I really liked Anis's conversation, part of the conversation where she talked about self-reflection. I think that's a critical piece to that. Another piece that I would say is really adopting a cultural humility framework.
Yeah.
I think that's key to
Yeah.
this.
Yeah.
There's so many elements there
Yeah.
we could talk about.
Yeah. Ernestine, knowing a little bit about your work, how has everything that's happening, how has that impacted staff and students? We've talked about patients, but how has that impacted staff and students?
I think it's had a really interesting, just as diverse as our staff and students are, just as diverse are those reactions. I think students were struggling, especially with the death of George Floyd and then followed by subsequent deaths. It was really, they were having a hard time focusing on their work, trying to make sense of it, really struggling to figure out what to do, how to respond. Many wanted to get political. Others were scared of the ramifications if they did. But I think they just had really diverse reactions. Same with staff. Some, just like all of us, some of them were angry and outraged. Others were really like trying to make sense of the world and really trying to figure out how can they turn that tide and do something different. So I don't know if Anise or Damon have anything else to add to that.
Yeah.
After you.
You sure? Okay. Thank you. No, I just want to echo that, and also just, with an emphasis on the diversity. Like, I think that, the experiences, they've been rather heartfelt, and some people have been a bit more, expressive than others. But, being a part of this Duke system, like, one would think there's an opportunity to change some things. And so I've been able to be in a number of conversations with individuals where they're almost, they're also energized when it comes to being part of that change.
Yeah.
Damien, you were going to say something?
Yeah, I certainly feel like there's been some of that energy I've seen come out. People are sort of taking a closer look at their own environments, whether it's the School of Medicine or whether it's their own clinical department or wherever it may be, where they find themselves, and sort of taking hopefully taking a new look. I think there's also two other things. One is that are sort of things that always consider when you think about this. One is just the balance of trying to navigate this new opportunity with your pre-existing academic and clinical and professional and family obligations. And so this idea, there's a term that's bandied about a lot called a minority tax, right? So how do we sort of navigate that space of using this opportunity for good, but also still taking care of ourselves in that same space? And that's a conversation I've been having with a lot of individuals. And I'm always constantly thinking about that myself, my own balance that I need to strike personally. I think there's also this issue, because you think about our society now, things have happened. There's been a lot of rapid sort of change in some ways. Things that maybe 5 or 10 years ago wouldn't have imagined happening so quickly, right? You know, it's like some certain, you know, whether it's issues with like Confederate monuments or whatever may be the case, there's a lot of overnight sort of changes, renaming things, and maybe there's energy towards this change. But I think there's also for some, there's this sense of I can't get myself too my hopes up too much in some way because we know that this could stall and then there could actually even be backlash. And I have to in some way protect myself or guard myself from that. So you sort of see these people, you sort of see people sort of navigating both of those spaces, the energy and desire to change, but also this sort of sense of self-preservation and sort of balancing those two.
Yeah. Oh, yeah. Yeah. People don't often talk about that, but, you know, the combination, as you describe, of hopefulness, but at the same time, you know, sort of holding something back, you know, not
Yes.
concerned whether a month, 3 months, 6 months from now, things will go back.
Right, exactly.
Yeah. Yeah. You know, in psychiatry, and we've all been involved in the work we're doing, what I think is some really important work. And I wonder, Nice, you're co-leading much of the effort in psychiatry. Are there things that we've been discussing and planning that you think might be applicable to a wider audience? You know, School of Medicine, all of Duke? Yeah.
Sure. Yeah, that's definitely one of the very exciting parts of what I do. So as you stated, you know, it's been an eye-opening experience, nothing short of a privilege. You know, I've had an opportunity to have countless conversations with individuals that remind me of the reasons of why we are driving the mission forward to dismantle racism. And it's one thing to wonder if racism plays a role in your life. And then it's another thing to actually read about it, see it, and talk about it. And that's one of the things that we're doing in our series of work groups. So, you know, one of the things I just want to be super specific around, like my personal experience, like I personally am energized by the conversation and because I get to contribute to the discussions and witness change right before my eyes. I get a chance to work with various bold teams that are clear with their recommendations and strive towards dismantling racism. So that's one of those things, it's the parallel process. The skills that we're exuding in our workforce are essentially helpful for the specific mission, but it translates into other areas as well. So we're organized in our delivery and we're committed to the work, you know, having rather tough conversations, you know, not the easiest amongst ourselves and trying things out. You know, one of the things I have to remind myself in doing the work is I appreciate the idea of trying one thing and seeing if it works. And if we need to try something else, so be it. But we're laying out recommendations for action, and quite honestly, it's rather inspiring. And I ultimately am eager to speak with colleagues about ways to improve access to people of color. And I think anybody that knows me, every chance that I get, if I'm in a Zoom room, you know, there isn't many times where dismantling racism doesn't come up. Somehow it appears in the conversation. And the biggest takeaway in doing the work is taking risks. That's the big thing that I've learned. You know, like we don't have any time. We don't have any more time to mull over too much. And you know, listening is big, responding is big, action is even better. And anyone that knows me is aware that the time is now. And every time I speak with a sense of urgency as we need to get things done.
No, I appreciate that and really appreciate your leadership. Yeah. I'd like for you to, and this is everybody, you know, what kinds of things need to happen structurally? And we've, you know, spent some time talking about clinicians, but in terms of structures that might contribute to better care, better access to mental health services for people of color, what are some things that have to, in your opinion, have to happen, you know, in the education, preparation of people who enter the mental health field and are likely to treat people of color? What needs to happen more broadly in terms of insurance structures? I mean, what are your thoughts about what would contribute to better systems? Ernestine, you're about to say something.
Don't all speak at once, right? That's a big question, Ben.
Oh,
Yeah.
Bill, you're the expert, Ernestine.
Right? Like that's like the whole elephant, not even the piece,
Right.
not even the trunk.
Because I don't have any idea, so I thought I'd ask the experts.
I think, I think we have to look at ourselves, look at the systems we've built, educate ourselves about history. I think that's so important because I think if we don't do that, we're bound to repeat some of the same mistakes. I don't know. I'm always inspired when I talk to Anise. She's always like pushing me to think like, what could you do next? How could you do it now? Today, right now, this minute. And her urgency is just always palpable. So I think we need a bit of urgency. I think we need intentionality and to be strategic about how and what we do, and how and what we ask people to do in response to these things. So I think it'll take a lot of different pieces of the puzzle to, really get the system changing in a meaningful and a sustainable way. But those are just some things. I'm curious what my fellow folks would say about this.
I think about the education piece and understanding the historical context of racism. The fact that you could go through your education, whether it's a, MSW, PhD, MD, work in the mental health field with populations of color, and have little formal exposure, informal exposure often, to the historical context of race in America. And then you're going into communities where there are Black and brown people. Yeah. So the history piece is important.
Yeah, that very much echoes my medical training. So I think, went through 4 years of medical school, basically had like would amount to a couple hours in one afternoon to talk about race. And you think about, half the patients that you're seeing, particularly at that time were African American. And like, what is that context, right? What is that history? You go through psychiatry training and very similar sort of experience. It wasn't until the last year, like the last year of residency training that they talked about race. But by that point, you've already gone through 4 years of training. It's like you needed that from the very beginning, right? So I think you have to be very much intentional. And it has to not just be a lecture or a seminar. It has to be something that's built into every component of the curriculum, because if you don't do that, you're just going to continue to miss opportunities to address change and to perpetuate, the problem. So, I think that's from the education piece we have to do. But then, there's obviously larger structural piece in terms of the way that, in terms of mental health, in terms of the way the systems are funded, the way that it almost creates two-tiered care. And you just see it so often. And in some ways, in mental health field, it's even more accentuated than it is in other areas of the medical field. And you would just sort of see this sort of thing play out in a very troubling way, where this is the sort of care that this person can get with this sort of with the alcohol or drug problem, and this is the care that someone else can get, and it's as plain as day that there's differences. And sometimes people would try and explain it away, but you're really just sort of grasping at straws to sort of explain that disparity, other than the fact that the system has allowed this to happen. And we have to be intentional about how we can systematically make those sorts of changes. And until we do that, these things will continue to perpetuate themselves. Things that may seem on their face race neutral can often play out very, very much in a way that disproportionately harms African American and other patients.
Yeah, you're all talking about intentionality. I appreciate what you said, Ernestine, about intentionality. It's not going to happen just by chance. I mean, systems and individuals and leaders need to be intentional.
Yeah, if I could just add, just in reference to when you hear the word structure, it's pretty mighty, right? And so, a wise man once told me that if anyone is really attempting to dismantle, systemic and structural racism, one has to make bold moves. So the idea of being gentle, and almost like making it seem as though it's optional. And if it's an optional, whether or not we're going to fix this, then we may lean towards not doing it, unfortunately, as a system. But if it's required, if you really examine, doesn't even have to be too complex, structural that's essentially pretty solid. It's harder to move it because it's essentially structural. So, we have the power as a system to do it. And so it's essentially making it happen and not being timid about it and not wondering, if this is the right thing to do or the wrong thing to do. But we all agree that there needs to be some change.
Yeah,
so acting on that, with a very bold sense, one would think so many wonderful things could come from that.
Yeah, no, thank you. Yeah. Going back to an earlier comment that was made by a couple of you about the stigma in many Black and brown communities, what kinds of things can we do to begin to, chip away at that? Because it's not as strong as it was for my parents, but boy, it still exists in brown and Black communities. What are some things that might help?
I think you're seeing some of that already. I mean, certainly this is a long-standing kind of a challenge, right? And so, because so much of the narrative, particularly by my parents' generation, was being strong and being twice as good and and not being perceived as weak, and all those sort. And also the idea of even it was built on community. The idea of like going to a stranger who is of a different background to you, and then to share all of your life's problems, just seemed like an alien sort of concept, right? And so I think it's, how do we normalize that? How do we share the stories of people who've done well? I know that I've done some searches online and seen that there's quite a bit of like Black therapists, groups that are pretty active on social media. I think to the extent that we can continue to sort of, systematically kind of destigmatize it, and also, but I think that also is incumbent upon the mental health system to sort of find ways to meet people where they are as well, and not rely on the same old ways they've always done things, and expect people to just sort of automatically just sort of adapt to that. I think it has to be a bi-directional kind of thing. I know there's some people who've done it. There's some psychiatrists who've done some work in Black churches, and they found ways to sort of make inroads there. We even developing partnerships sort of bi-directionally, and also find that be helpful. So I think it's just meeting people where they are. I've even heard about some where they've gone up to Black barbershops and tried to sort of do this sorts of things. So there are just many ways in which you can kind of, it just has to be very intentional, and just thinking about things in more creative ways.
Yeah. I know, Ernestine, you talk a lot about resilience and creativity.
Yeah, I think you got to be flexible. You got to be creative. I think you have to meet people where they are. And I really think that we have to start having the conversation. I think part of the thing that gives stigma so much power is the lack of conversation about it. Name it and kind of say, mental health problems exist in all races and cultures, and that we have to fix it. Even if you go back to your history, you will know that back in the 60s, Black and brown people couldn't go and get, mental health services in the same places as white folks. Many times they were refused services. Many times they were treated differently. And so I think we got to change that narrative and really kind of shake things up and really, share what works. And, a large part of my work is disseminating evidence-based treatments in communities all across North Carolina, and that's Black and brown communities as well as other communities. But what I'm finding is some of the communities I'm in and getting evidence-based treatments to, I haven't seen that. And it's unfortunate that in 2020 that they can't get quality care. And so it's really incumbent upon us to think about ways in which we do what we do best for everyone and create that sense of equity in mental health care.
Yeah. You mentioned conversation and dialogue. A lot of that has happened around the country in the last month or so. What are some things that are important to think about when we start having these authentic conversations? What are some guidelines? And these, I know that you've played a role in putting groups together and creating that dialogue. What are some pointers for real rich, authentic, productive dialogue,
Yeah.
within homogeneous as well as heterogeneous groups.
Yeah, you're absolutely right. I've been in a number of conversations, and you know, believe it or not, showing up for people in an authentic way, essentially like naming a safe space, like obviously laying out some expectations around respecting each other and providing space to talk. But you'd be surprised if you ask someone, you have an opener asking someone, how are you? And waiting for a response. It goes a long way, and also like, so, like active listening is key, and showing up as a support, huge also. And especially if someone knows that you're listening with intention in order to, like be a part of a solution, it goes a long way. And I like to think that, I'd rather have an awkward conversation than no conversation at all. Like I've heard that a great deal. And then we the one of the things I've noticed in some of those conversations is there's a theme. We're working with a number of people that have chose to be in a field where they wanted to help people. That's a commonality to improve the quality of life. And that's the one thing that brings everyone together. We all have an opportunity to pick a side and do what's right. So I like the idea of laying out historical perspectives, as my colleague recently just said. That's clearly an opener because, you'd be surprised, people tend to forget. But really, active listening goes a long way, and showing up to people in authentic ways. The feedback that we've gotten is it's been a rather helpful forum.
Yeah, I think you got to give yourself some grace and give all the folks that are trying to enter into the conversation some grace. We're not going to get it right every time, and it's okay. I think just start to engage in some of these conversations. You mentioned, Anise, creating safe spaces, and I would go one further and say brave spaces where you take some of those risks and you talk about those things that are most challenging. And I think with that and the intention of really kind of moving the needle, we can get a fair part of the way. We still got a lot of work to do, but I think that's a good place to start.
Yeah, I just want to add one thing. You're right,
Sure.
Ernestine. And also, I think like you have an opportunity, if whoever plans on holding spaces, they should be having spaces individually. So like you don't want to go to a group, be able to like use that group to deal with your own challenges. I think people need to have groups amongst their own teams separately, to be, even if it is a conversation that could lead into something else, because then you're almost getting into the practice of it. I most certainly do it, with my team. I hope they value it, but I do it every chance that I get.
Yeah. And Damien, you write a lot about the challenges you've had in your own life, your own professional development. Have you seen changes in conversation, authentic dialogue from when you were in school, when you were in training, and now in this professional context and the people that you mentor? Have conversations changed significantly, or are we still talking about the same thing in the same way?
No, I mean, I would say in the medical orbit, it's been a lot of change fundamentally because when I was coming through, this conversation was like really off the table. I mean, this would have really been just at the margins. A few students may have had some chatter about this, but it would not have been in any way, shape, or form this level of interest. And I think part of that is, and I credit the students themselves, the younger generation that's sort of coming along to help force that conversation. I think in my generation was much more passive and sort of kind of going along to get along, if you will, and is trying to make the best of the situation, knowing that it was better than when our parents were around. But I think our younger generation is really sort of pushing the needle in a much more active, aggressive way, a very courageous way, honestly. And so I think that's putting things on the table in a way that wouldn't happen before. So I think that's what gives me the most encouragement looking forward. A lot of that's been the dialogue that they're forcing. Yeah, so I think that's the biggest change for me. Just on the point about team. So I belong to a over at the VA. I'm in a kind of a very multiracial team. It's like, I mean, if only the world could work the way that our team works together, it'd be like, wow, we could all just wouldn't it be great. But we had a couple of dialogues the last few months, and one of the starting points was just talking about like not making it so that just the Black team members were the ones that are having to talk, and sort of having where the other team members have to sort of let's just we'll be quiet. Let's see you guys talking about this sort of uncomfortable issue. That was really interesting. That was really fascinating to sort of see. We learn new things about each other, even though we've known each other for a long time. And in some ways, I think it brought us closer. And it's interesting, you can know people for so long, but sort of these certain conversations have been kind of out of bounds in some ways. And sort of, like I said, being brave about it and having these conversations has been really helpful for us moving forward and thinking about the work that we do.
Yeah. I mean, authentic dialogue is important as a prerequisite or a co-requisite to change. But we don't want anyone to think that having the conversation, is the end point.
Right.
I mean, it's a prerequisite, sometimes a co-requisite. But if we don't have, in Anis's word, bold action,
right,
then we're in this loop of dialogue. Yeah. We're going to run out of time soon. So I'm going to ask, for kind of closing comments, anywhere you want to take it in terms of race and mental health. But how would you sort of sum up your thinking about race and mental health?
I could start us off.
Sure.
I could start us off. So, like we've been in and we've seen a lot in the Duke community. Like it's been an honor to share some of those experiences. And I hope the takeaways for us and those around us are, we had a chance to watch Living While Black and participate in turning a moment into a movement. We've watched Black men at Duke, Black women at Duke, and we've witnessed our colleagues open up about their experiences so that, and essentially what that does is it gives us an opportunity to be empowered by the shares and do better and show up for individuals in the mental health setting. And, I do want to thank all of those who have come before us to share their experiences, their strength and their hope, to like essentially embarking on this new day. I think that courage exudes many of our colleagues and it's an inspiration. And I'm hoping that we can continue to pave the way as we dismantle racism in the mental health field and beyond. I just want to make mention of that.
Thank you.
Yeah, I'd say, I can't really put it any better than that. I think all those things are extremely important. Just echoing, the points about the dialogue, but also turning that dialogue into action. Just also finding ways to systematically think about, and maybe I shouldn't use that word, but just thinking about each step along the way and each point in which we're interacting with a student or a learner or a patient, how might we be sort of poisoning that, or how might the history that we have be interfering with what we need, what we want to happen? You need to think about that at every single step of the way, and not just from our end, but also, again, I can't stress how important it is for providers to think about what is that patient's story, what are they bringing to the table, how might they be, and how might that impact how they interpret your actions, your words, your behavior. I think all that's just so important. I think systems need to do that as well. And if an institution is trying to create a trust with a community, how do we think about the history and intentionality with sort of addressing those issues? I think those are, the opportunities here. Again, I have that guarded. I'm guarded in some ways, but there's a hope as well that that things can really move forward. And again, things are better than 20 years ago, but again, there's still much more that needs to happen, and we have to be very step by step intentional in how we break down what those changes need to be.
Thank you.
Yeah, I would just add that I love the energy of the young people. I love the energy of the old people getting back into the game too. And I'm just cautiously optimistic. I think I have to be optimistic that things will change. I have to be optimistic that this is our opportunity to get it right. Because if not, it doesn't look so good. It doesn't feel so good. So I am cautiously optimistic that the time for change is now, and that we have within our midst everything that we need to get this right and to do this over and better. And that we just got to get in there and be bold, as a wise old man used to say, with our intentions and our actions, and make it happen. Right, Anise?
Yes, correct, correct.
Thank you. Thank you. I mean, thank you to the three of you. We're really so fortunate to have you here at Duke, have you in psychiatry, and you know, you've provided some insights and thoughts I certainly am going to reflect on. And I think the takeaway, or one of the takeaways I hear, is that the door is open, and it really is up to all of us at Duke, in the School of Medicine, in psychiatry, to push it open and walk through. But the door is unlocked, and we have an opportunity. And thank you. This conversation has been recorded, so it'll certainly be available. If you have additional questions, you can certainly put them in the chat, and we'll respond to them. But I thank you to all of you who've been listening in, and I trust that you'll each take your responsibility in walking through that door and helping us change. Thank you.
Thank you.
Thank you.
Thank you.
Thank you.
Oh.